Hello. Welcome to the overview of the 2023 AGS Beers Criteria Microlecture 3. This is the third of a series of 3 microlectures designed to give an overview of the 2023 AGS Beers Criteria. My name is Rebecca Brynjulsson. I am a board-certified geriatric pharmacist and School of Pharmacy faculty member at North Dakota State University in the School of Pharmacy. As we begin this presentation today, I would also like to acknowledge board-certified geriatric pharmacist and NDSU School of Pharmacy faculty member, Mark Dewey, who also contributed content to this presentation. At the completion of this series of 3 microlectures, the participant will be able to identify basic principles of medication use in older adults, summarize the changes in the 2023 AGS Beers criteria, analyze patient cases to identify potentially inappropriate medications and understand their role in common prescribing cascades. Identify practical solutions to reduce potentially inappropriate medication use and polypharmacy for providers. As a refresher from Microlecture 1 and 2, the 2023 AGS Beers criteria are organized into 5 tables with the following titles. 1. Medications considered as potentially inappropriate, Table 2. 2. Medications potentially inappropriate in patients with certain diseases or syndromes, Table 3. 3. Medications to be used with caution, Table 4. 4. Potentially inappropriate drug-drug interactions, Table 5. 5. Medications whose dosages should be adjusted based on renal function, Table 6. The quality of evidence ranges from low to high, and the strength of recommendation ranges from weak to strong. As we conclude this microlecture series, we're going to look more specifically at deprescribing and prescribing cascades. First, let's review the definition of deprescribing from Microlecture 2. As you may recall, it's more than just telling a patient to stop taking a medication. Krishnaswamy and colleagues provide the following for us to consider. Quote, a comprehensive definition of deprescribing should include 1. An organized process of medication removal or dose reduction. 2. Oversight of the deprescribing process by an appropriate member of the healthcare team. 3. A goal of improving one or more specific outcomes. 4. Consideration of an individual's overall physiological status, stage of life, and goals of care, end quote. Let's look to the literature on deprescribing. Huffmeyer and colleagues in their 2021 article in the Journal of the American Geriatric Society titled Primary Care Clinician and Community Pharmacist Perceptions of Deprescribing sought to better understand deprescribing. The citation is provided on this screen and in the reference section. The researchers surveyed primary care providers and community pharmacists in Kentucky between December 2019 and February 2020. A total of 58 primary care providers responded and 248 community pharmacists. Quote, survey questions address deprescribing experiences, beliefs, attitudes, influencing factors, barriers, and facilitators, end quote. For results first, we'll look at the clinician and pharmacist barriers identified. The most identified clinician barrier was, quote, patient attitudes toward the medications they take, end quote, 69%. The most identified pharmacist barrier was, quote, difficulty to communicate directly with other healthcare providers, for example, subspecialists, about deprescribing recommendations, end quote, 56%. You also see the bottom 2 clinician barriers identified match the top 2 pharmacist barriers identified, and both groups identified as the number 2 barrier, quote, insufficient time available to spend with patients and communicate deprescribing recommendations, end quote, with 58.6% of clinicians identifying this barrier and 49.6% of pharmacists identifying this barrier. Both pharmacists and clinicians agreed that, quote, lack of education and training related to deprescribing activities, end quote, 21% and 20.7%, as well as, quote, lack of access to information in electronic health records, end quote, 26% and 20.7% are barriers. Next, we'll look at the clinician and pharmacist factors identified that would facilitate deprescribing. The most identified clinician facilitator was, quote, adequate time to spend with patients to discuss deprescribing recommendations, end quote, 50%. The most identified pharmacist facilitator was, quote, ability to communicate directly with healthcare providers about deprescribing recommendations, end quote. You can see highlighted the facilitator in common for both clinicians and pharmacists. Although not an identical facilitator factor, we see trust between patients and providers also plays a role in facilitating deprescribing. Both pharmacists and clinicians agreed that, quote, training and experience with deprescribing, end quote, 27.4% and 37.9%, as well as, quote, clinical guideline updates that support deprescribing recommendations, end quote, 25.4% and 34.5% are facilitators. Overall, time, communication barriers, patient buy-in, and educational support in learning more about deprescribing are common themes for both barriers and facilitators for both clinicians and pharmacists. Potentially inappropriate medication use may result from prescribing cascades. According to Sternberg and colleagues, quote, a prescribing cascade refers to the sequence of events in which an adverse drug event is misinterpreted as a new medical condition, leading to the addition of another, potentially unavoidable medication, end quote. Next, we'll spend some time looking at the article by McCarthy and colleagues titled Think Cascades, a tool for identifying clinically important prescribing cascades in older people. The citation is provided on this page and in the reference section as well. This article was the result of a multi-phase Delphi study, where a panel of experts came to consensus over several rounds on the prescribing cascades included. We'll look at what they found, and the 2023 AGS Beers criteria findings for these medications as well, if available. The first grouping of medications we'll look at from the Think Cascades article are medications related to the cardiovascular system. The authors identified the first medication prescribed, followed by the observed side effect of the first medication, and then the medication prescribed to treat the adverse effect of the first medication. Each row represents a prescribing cascade. First, we see calcium channel blockers prescribed with peripheral edema as a side effect. Patients are then prescribed a diuretic to treat the peripheral edema if the adverse effect is not identified. Next, we see diuretics being prescribed that result in patient experiencing urinary incontinence as an adverse effect. Overactive bladder medications are then prescribed to treat the adverse effect. References to diuretics do appear in the Beers criteria related to specific drug-drug interactions. One example is a drug-drug interaction identified in Table 5 between loop diuretics and non-selective peripheral alpha-1 blockers with the following recommendation, quote, avoid use in older women unless conditions warrant both drugs, end quote, due to, quote, increased risk of urinary incontinence in older women, end quote. The Beers criteria also indicate, quote, data are limited for selective peripheral alpha-1 blockers, but may apply as well, end quote. Antimuscarinics used for overactive bladder do appear in the Beers criteria due to their strong anticholinergic properties and the adverse effects associated with anticholinergic medications. In this example, a potentially inappropriate medication with strong anticholinergic properties may be prescribed as a result of a prescribing cascade. The second grouping of medications we'll look at from the Think Cascades article are medications related to the central nervous system. First, we see antipsychotics resulting in extrapyramidal symptoms, which result in the prescription of an anti-Parkinsonian agent to treat the observed adverse effect. Then we see benzodiazepine use resulting in cognitive impairment, then resulting in the prescription of a cholinesterase inhibitor or memantine. Next, we see benzodiazepine use resulting in paradoxical agitation, or agitation secondary to withdrawal with an antipsychotic prescribed to treat the observed adverse effect. Finally, we see selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors resulting in insomnia, which then results in the prescription of a sleep agent, benzodiazepines, benzodiazepine receptor agonists, sedating antidepressant, or melatonin. Many of these medications are included in the Beers criteria as medications to avoid and/or limit use of in older adults. Specifically, we see recommendations for benzodiazepines, selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors, antipsychotics, and all CNS active medications. The third grouping of medications we'll look at from the Think Cascades article are medications related to the musculoskeletal system. The first class of medications prescribed are NSAIDs, which result in high blood pressure. Then, an antihypertensive medication is prescribed to treat the adverse effect of the first medication. The Beers criteria does have comments spread throughout the tables. on antihypertensives and specific antihypertensive medications in relation to use in specific older individual patient care scenarios. The fourth and final grouping of medications we'll look at from the Think Cascades article are medications related to the urogenital system. The first prescribing cascade we see is urinary anticholinergics, resulting in cognitive impairment, which then leads to the prescription of a cholinesterase inhibitor, or memantine. The next prescribing cascade is an alpha-1 receptor blocker, prescribed which results in orthostatic hypotension and dizziness. As a result, a vestibular sedative, for example, beta-histine, antihistamines, or benzodiazepines are prescribed. Many of these medications we're familiar with from the Beers criteria, including urinary anticholinergics, alpha-1 receptor blockers, antihistamines, and benzodiazepines. In general, we can see that medications prescribed can cause adverse effects as identified on the Beers criteria and in drug information resources. If we don't identify the side effect as an actual side effect and adjust the first medication prescribed, it can result in the addition of additional medications leading to polypharmacy. Using resources like this, commonly identified prescribing cascades, along with the Beers criteria, can help us to avoid adverse effects or prescribing medications that may also cause harm in specific patient clinical scenarios. Let's practice applying what we've learned to a series of case scenarios involving the same patient over time. Let's practice applying what we've learned to a series of case scenarios. A 72-year-old female currently lives independently in the community in her home and is an active volunteer and substitute high school English teacher. As part of her visit today, her medications are reviewed for appropriateness. Today she reports her knees are bothering her quite a bit and she's been having difficulty sleeping, which is limiting her ability to be as active as she'd like. Her past medical history includes hypertension, diagnosed May 2013, dyslipidemia, diagnosed May 2008, and osteoarthritis in both knees. Her vital signs and lab values are listed on the page along with her current medications and the resulting prescriber recommendations. Please pause for a moment to review this information before moving on to the next screen. Do you agree with these recommendations? There is a potential for a prescribing cascade present. The prescriber prescribed NSAIDs, even though the patient has hypertension. It is possible that the patient's blood pressure will increase. Also, temazepam, a benzodiazepine, was prescribed for sleep. This is the second scenario, same patient, however time has elapsed. A 73-year-old female presents for follow-up. It's been 6 months since she last saw her provider, who is currently out of the office on personal leave. She currently lives independently in the community in her home and is an active volunteer and substitute high school English teacher, although she's not sure she'll keep substituting. She states, "My memory isn't what it used to be." Today she reports her knees have been feeling better and she's sleeping better. She had her blood pressure checked at the senior center screening event last week and it was 152 over 90 millimeters mercury. She checked it at home yesterday and it was 150 over 88 millimeters mercury. Past medical history includes hypertension, diagnosed May 2003, inadequately treated until 2013, dyslipidemia, diagnosed May 2008, osteoarthritis in both knees, and insomnia. Her vital signs and lab values are listed on the page along with her current medications and the resulting prescriber recommendations. Please pause for a moment to review this information before moving on to the next screen. Do you recognize the potential prescribing cascades? The patient is beginning to have memory problems, perhaps as a result of the benzodiazepine prescribed for sleep. Her blood pressure is elevated, perhaps from the addition of NSAIDs to her medication regimen, and now amlodipine has been prescribed. This is the third scenario, same patient, however time has elapsed. A 73-year-old female presents for follow-up. It's been 6 months since she was last seen. Today her daughter is with her. She currently lives independently in the community in her home, but her children have become increasingly concerned. She seems to have gotten more forgetful in the past year, and they wonder if she might be developing early stages of Alzheimer's. Her daughter also reports that both of her mom's ankles have been slightly swollen as well. Her blood pressure checks at the senior center have all been good according to the patient's daughter. Past medical history includes hypertension, diagnosed May 2003, inadequately treated until 2013, dyslipidemia, diagnosed May 2008, osteoarthritis in both knees, and insomnia. Her vital signs and lab values are listed on the page along with her current medications and the resulting prescriber recommendations. Please pause for a moment to review this information before moving on to the next screen. Do you recognize the potential prescribing cascades? The patient continues to experience worsening cognition. Today has bilateral swelling in both ankles, which are a possible adverse effect of the calcium channel blocker added at the last visit. I hope this case example illustrates how easy it is to miss potential adverse effects over time and create prescribing cascades. It is good to always consider if medications are causing side effects resulting in symptoms before adding a new medication. This concludes the final AGS Beers Criteria Microlecture. This slide provides the references for the presentation. Thank you.